want to mention one thing here. A lot of MI patients, like post-MI patients, when they leave, nobody even thinks about, do they have depression? What caused this event? What happened? I asked a group of care management and disease management and all these people, and they said, we talked to them about diet, eat this, you can't eat that, you have to take your medication. Are we really thinking what's happening with this patient? So let me tell you a story, and I don't know, is this on? So I can move a little bit or I can stay here, doesn't matter. So let me tell you a story of a patient that's in a Nevada market. So this patient actually is a 77-year-old male who is our patient, and he's on another high-risk program. He's had an MI in the past. He's got CHF, COPD, diabetes, hypertension. He's living. So my team, I was talking to them about enrolling patients quickly into these programs and into the high-risk program. And my team was like, yeah, we're trying to get them motivated, get them involved in this chronic disease management program for high-risk patients. And I was like, why is it taking time? So one of my health educators, she said, I want you to come next time you come to Nevada, I want you to come with us to one of our patient visits, because they actually go to the home of the patient and try to enroll them. So I said, okay, I'll go, I'll see what I'll see what the barrier is. I was sure I could tell them how to do it better. So I went with them, and I was so amazed to see the poverty he was living in. I haven't seen even such poverty in India. So it really made me, I was literally in tears when I saw. He lives in a house, a broken down house, but he's renting a room for $75 a month. And the whole house may not be more than, to where you're sitting, Carol. And they had a room and bed for him, something separated. And he's paying $75 to a family. There's one bathroom, family of 4 kids and a mom and a dad. And the kids were sitting on the ground with the dog licking on the bread, and there were cockroaches all over. And I said, this is the patient population that we're trying to help. So that's reality today. And we're still trying to see how to take care of these patients. So I just wanted to bring you guys to that, then I never kind of spoke a lot of things, what we can do and what we should do, because the reality is trying to help patients in these areas. So you can imagine if they have depression and stress management, and that means there's a lot of things to do, right? So, I just put that out there. Maybe we need to have artery softeners. That could, help, right? Because I can imagine a lot of patients saying, we take Metamucil and we take this, why can't you do this for us? So my group, focus group discussions and perspectives. So, when I talked to the patients, they said, well, what is that? A rehab? Doctor, I'm not taking drugs. I said, no. This is, cardiac. They've never even heard about it. The cardiologists, the PCPs tell me, well, it's the cardiologist's job. They should be thinking about it. The cardiologist says, well, no, they won't go anyways. Why should I waste my time? I mean, we had lots of conversations, but these were the main points. As an organization, when I talked about this, they said, we used to have that, and we were paying, and that's true, we did. Once upon a time, I was involved in it, when we had a doctor called Dr. Hart. His name was really Dr. Hart. And, so he used to do a really good job. And then rehab facilities told us, oh, we're capitated, and we try to bring every patient in. They don't continue, but that's not our problem, right? And then the physiotherapist said that we're going to the home of the patient said, well, in a new pilot, which I'll be talking about, said, well, I'm getting some traction because there's technology involved, and now I'm on top of them, they don't have to travel to places. So one of the things I would say is be patient with patients who are not patient, right? Many of them are not. Unfortunately, it's difficult. So what I would like to say about cardiac rehab is it's missed opportunities. So it clearly improves patient survival. You can look at literature, and I'm sure Rand Corporation may have a lot of data behind it. It improves quality of life, functional status, cardio risk profile, reduced risk of second heart attack, which is the biggest fear, right? Improve mental well-being. So then why aren't we doing it? The benefits, everybody knows that, right? You ask any healthcare provider, it's not new information. There are a lot of myths that I found out that a lot of cardiac, patients, they say, oh, we are going to go exercise over there? Oh no, oh God, no, I need to rest. So they think, they don't need to condition, they need to be bed rest, not even move a muscle. So many of them don't have the time to work out. They have to go so many times, like 36 times, to a cardiac rehab. I mean, forget it. Even if you tell someone that, they're like, how are we gonna go? First of all, I need to take somebody with me. Then, transportation. There's so many, we've created programs that there's no incentive to do them, or there's no way. It's just, a lot of times I feel in medical organizations and, the thinkers of how to make things better for a patient is all only about, we're just thinking about what we need to just put in paper. It's not outcomes oriented, it's task oriented. Not sure if they can afford, because a lot of people are asked to pay co-pays, and they said, that's a lot of money. You guys are doing that, that's another way to get money out of me. So that's the other attitude. Feels like they know everything, and they say, you know what, my grandmother got this, and she did this, so they have their ideas already. So we spoke about it, factors that impact participation, and these are all the things that, and many of them are even embarrassed to talk about. They have to now go to rehab. And so the time, the distance, it just seems to me that it's not easy. I can tell somebody, it's like the, awakening I had when I went to that patient's home, because then I didn't say another word to the health educators. Otherwise I was giving them all the plans of the world. But the same way, when, you put your plan, great. But the reality you have to look at. So one of the things we thought about is, let's not call it rehab, let's call it cardiac rejuvenation. Maybe the RightCare initiative can come with a new term, new word for it. Ways to increase participation rate. So home-based cardiac rehab is one way we looked at it, from in the Nevada market especially. Primary care physician involvement. How can I get PCPs involved more? Because patients seems to listen to the PCPs. Especially in our organization, they consider the PCP the God. So they say, anything PCP says, they're like, anything we tell them as population health, they're like, let me check with my PCP, if they have a good relationship with the PCPs. And then PCPs need to start thinking, once the patient is discharged, it's not just the cardiologist's job, it's also their job to actively participate. Use of modern technology. So, healthcare is the one, aspect that has stayed back in technology. Every other, if you look at anything, business, anything else, it's moved along so well in technology. Healthcare is really still not there. Somehow we haven't married the technology. So I have two brothers, and one is a pilot, and the other one is an aeronautical engineer. And they used to talk about technology like even 15 years ago, they would say, every jet engine that commercial planes carry, passengers, every jet engine is actually monitored while we are flying. So that as soon as they come down, they know exactly what's wrong and they can take care of it. And so there's, less delay. Otherwise, as it is, there's so much delays. We would see even more delays and so much money, right? So they were asking me, what do you guys do? Things like, how do you monitor patients? And I had no idea before 2010. now since 2011-12, we've been doing a lot of work in technology. How do we take care of these patients at home? Otherwise, we're trying to bring them to the doctor's office, and then there is compliance, and why are you paying for, taxi, why you not? So many questions. So we've been studying different technology and trying to give them Bluetooth-enabled sensors and trying to take care of these patients. So, one of the study that I looked at, the Brown study, found no difference in risk factor control, self-reported physical activity, and the distance walked on the incremental shuttle walk test when home-based compared to hospital-based, right? So we didn't find much difference. We looked at a lot of other data. Although cardiac rehab programs are mostly run by cardiologists, primary care physicians, I spoke about that. PCP involvement is very, very critical for improving the access for retention. So use of technology, again, help increase enrollment, reduce risk factors, improve benefit-cost ratio. Now, this is not a cardiac rehab study, but I just wanted to introduce that we did a heart failure program in California, actually, for 400 patients to reduce admissions. And we found, so basically what we gave them is Bluetooth-enabled blood pressure cuffs and Bluetooth-enabled weighing scale. And we found 30% reduction in the hospitalization rate among the intervention group compared to the control group. The p-value was 0.03, which was statistically significant. Readmissions within 90 days were 57% lower in the intervention group. And I can tell you, even today, the patients that were in our program were much more happier to, they were to engage with our care managers. They were also very good in self-management. They asked the right questions, so a lot of engagement. And we're still benefiting, they're benefiting from that. Patient journey to cardiac rehab. So appropriate referral is very important even before they're discharged, right? Timely enrollment before they're discharged. They need to know what this is about. Not after the discharge and there's nobody to tell them. So maintain adherence, appropriate intensity, dose, duration times frequency per week. So high dose, 36 sessions, medium dose, 12 to 35, and low dose. So the cardiac rehab pilot, we only have 50 patients in it, and I'll tell you what the pilot, this is the result that we found. So this is the pilot. So basically when they're discharged, on day 1 to 2, we have an in-home assessment with cardiac health coach. And then we have, so you can read about all the in-home assessments that we do. Medication reconciliation, very, very important. Because these patients are on multiple meds, their meds went out, the dose was increased or changed. Lots of changes when they are discharged. So we want to make sure, that you read the in-home assessment, baseline assessment, environmental assessment. We see, how's their home, we look at fall prevention, we look at many things because we have somebody going into the home of the patient. Education on their condition, therapy, equipment, devices, whatever devices we're giving them for the, all the Bluetooth-enabled devices. And we also have a therapist with the cardiac health coach, showing them some of the exercise, showing them about the importance of walking. First day, take a few steps, then increase that number of steps. And then we mod video appointments, so they all get an iPad or an Android device, and so we keep the communication with them. With this, we are able to see that patients are more engaged and they don't have to travel somewhere. There's less cost involved, and we are actually partnering with the physiotherapy department to do this. And we are already seeing great results. It's 200 patient study. I only have 50 patients enrolled in each arm. It's matched cohorts, so randomized. So we'll see how the results come out after 200 patients. Cardiac rehab is underused, so that's a conclusion. We can all agree on that. And I can tell you, if it's happening in our organization, it's not happening better in another organization or nationally. can improve quality of life, we know that, can reduce morbidity and mortality, improve referral process, use of technology to enhance the program. There are only 4 kinds of people in the world: those who have been caregivers, those who are caregivers, those who will be caregivers, and those who will need caregivers, right? So I think that's the main reason we have Right Care initiative, because we may all be, if we live long enough, we might all be in those shoes. Questions?
The video, every week you have a video appointment, which is great. And that's like by FaceTime or iPad?
FaceTime,
Right.
yeah.
And have you had any problems with use of that technology in this patient population?
So as of date, we've tested for different, now we have CHF program like that, COPD program like that, diabetes, we're designing that, and high-risk program. As of date, we've tested like 70 different technology companies, and it's very cumbersome because many of the technologies are made for people that, like our kids who don't want to talk to you, and they already,
Yes.
they can text and they can, but the 1 or 2 technology that we found, it's only 1 touch, the patients don't have to do anything. It's already set up, so we're using that technology now. Yeah, it's very easy, yeah. Because some of these patients have never even seen a smartphone in their life.
I got my mother an iPhone, she can't even.
But this is like so easy, they don't have to do anything. They keep these iPads or Android device in the home of these patients, and data is just transmitted.
I think, Carol, to your point, the evidence, if you look at the data, is up until about 80 years of age now, people can use these. Once you get past maybe 85, then trouble, but...
I have a couple of questions. One goes back to something you said, you mentioned cost. But cost, not only in terms, my question is cost in terms of the patient cost, but did you have any trouble talking about dealing with and convincing your administrators of the cost savings, even if they put out some money to alleviate the cost barriers to the patients? So that was the first question. And then I'll come back with the second question about the
Yeah, so the first, to answer your question, yes, every time, any new intervention you want to do, the administrators will say no, that cannot be done. Many people will say, the cost, so you have to really dig their own data and show them, and then that's why we start with pilots. And then if the pilot goes well and they see the savings, then we move forward. And the patients had to give copay when they were referred. And our markets are very different in different states, different arrangements. So if it's a capitated auto referral, they may have to still pay in the initial visit. But with the home base now, there's no copay. The only payment now, there's no copay because we actually get those patients as we let them know that somebody will be coming to their home, but the patients don't pay for that. They're our members, they're capitated with us.
Okay.
Yeah.
But it would be interesting in terms of cost if you gave out bus tokens to see if that would improve, attendance on site, which led to continued decrease in utilization, which would be recognized maybe in less penalties for not meeting HEDIS criteria, et cetera.
We tried the bus token and things like that. Even then, we did not get, because the bus tokens are also not for 36 visits. They get like, one health plan gives them like 12 bus tokens a year. So they try to utilize it for the things that they want, not for the things that,
The second question I had was on group therapy. When I say group therapy, if you can get them into your on-site to continue the therapy by just having coffee or tea after their therapy session, and they can interact, they can bond, and it's a reason for coming out and coming and visit because they want to see a friend and who's like them, who has it. So it's therapy psychological, but it benefits the physiological.
So it's very interesting you say that, because a lot of these patients, sometimes, in a high-risk remote patient monitoring, they send these, we get alerts if something is above the threshold or below the threshold, right? Sometimes they just send an alert and a health educator calls them and they're like, oh, I just did that because I want to talk to you. So they do want that, so I understand that. So what we are offering to some patients is, do you want to continue this on-site? It would be really good, and we're thinking of bringing them on-site. Or once the program is over, they graduate, and then we tell them there's this possibility and get them to come, and they follow that. But this is so critical, the initial, so we want to make sure that they get it, because their heart gets conditioned and they're able to do. So we don't want to lose opportunity there.
Yeah, to follow up, I'm sorry, to follow up on that a little, so the YMCA, for example, has some successful programs with diabetics, and now they have similar stuff with cancer patients, and, called Livestrong. It's not just the coffee, and having social contact. It is getting to see other patients like you.
Yes.
And getting out of your head of whatever is holding you back. And basically the workouts are not like you've got to go to a physical therapist or physiotherapist. It's your group, and usually they mix it up with both the weights and some play, or like chair yoga or dance. Anyways, that has a lot of extra benefits, so
Absolutely.
I would like to invite Dr. Cesar
Thank you.
Aranguri up to be with us here and to share his slides with us. And I want to say also that, thank you, Riya.
Thank you.
We'll have So I just want to say that if it weren't for the rehab folks, I would not be here today. I had broken my ankle to smithereens. My foot was dislocated from my leg. And when they started trying to get me to walk again, I was just so frightened. But they worked with me in my home, and then eventually I got out of my home, and it just made all the difference in the world. So these people are absolutely wonderful professionals, and Keith and several of us in the room have benefited from rehab. So please keep at it. And we're so grateful that Cesar Aranguri is with us today. I have to say that I have a really bad asthma right now, so I'm not going to try to read his bio, but let's just say he leads the major cardiac rehab program for the County of Los Angeles. And if I'm outside of the room coughing, please pardon me, and thank you for being here.
Good afternoon, everyone, and thank you for giving me the opportunity to be here. Today, let me start by sharing with you a story, a personal story. Not long ago, I was in a regional meeting with all the cardiac professionals, sharing what they were doing at the facilities, talking about doing percutaneous intervention and having the patient ready to go home within 24 hours, doing surgical repairs of valves and even coronary bypass surgery, and on day 5 they send them home. And as we were at the table and they were telling their achievements, they said, "What are you doing?" I said, "Well, I'm doing cardio rehab." And there was a silence until somebody said, "What is cardio rehab?" Okay, so I said, there is a little gap here that I'll do my best to fill in. Cardio rehab, I have no disclosures, and I don't knowing what it is, what was going to be in the audience, so I kind of go over some of them, maybe overlapping with a third, like I'm already, and also by Fremont. But at the end of this, hopefully, I will be able to identify candidates for cardio rehab, what are the benefits of cardio rehab, and how we can educate the patient and the family. And that is a key word. For this, we must include the partners the family. It's not just the patient anymore. And that is what I mean. But this is simple facts that we already all know. Cardiovascular disease, acute coronary syndrome, the leading cause of death in the world. It's no longer, developed countries. It's even countries that are on the way to development. It's worldwide. In the United States, it's estimated as 200 billion with a B, the cost per year, and one of every 3 deaths is a result of cardiovascular diseases. This has, through the work of the cardiology community, has increased in the population that is very high risk to have a second event. And it's estimated that half of the cases of acute coronary syndromes are a repeat event. So there is a lot to do. And we know medications work, no question about it. And guideline-directed medical therapy has an incremental effect in reducing the mortality, and this is great. Also, the interventional strategy has made significant improvement here. Patient come with acute coronary syndrome, total occlusion of the right coronary artery, go in, put a stent, look at that, significant improvement. And the patient go home in 24 hours. Surgical colleagues have done tremendous advances in valve replacement, repairs, and also device therapy. A patient with heart failure getting cardiorespiratory therapy, improving quality of life, and also heart transplants. Dr. Cesar must share this story. But despite that this has improved, the record of events and readmissions are on the rise. And that is a fact. So that gives us a room to analyze the data and see how come there's improving medications, there's improving intervention, but still we see more and more cases. And a lot of them are repeat. So there's a need for secondary prevention, a very vigorous secondary prevention program that now will address what are the gaps. One of the gaps that we see is that there's identifiable preventable factors. A modification of those factors can lead to a decrease in readmissions and decrease of second events. Some of them are very clear. Diabetes. You can actually modify your eating habits. You can quit smoking. Our patients can do that. And educate the patients on physical activity, the safety of it, and as I was addressed previously, stress management. This is another big gap. As we have entered an era in which everything is timed, and length of stay in the hospitals are trying to be, one hospital trying to be the other one, trying to be more efficient. And so, I send the patient home after a CABG in day 5, it goes. Right. I open an artery and next day I send the patient home to see them come back within 6 months, and if they're lucky, otherwise within 30 days without readmission. Okay, so let's take a look at it. Just to give you an example, out of those modifiable factors, I chose this one because this is medication. This is what the primary cares, the cardiologists, and everybody puts focus in. Everybody had to be on guideline-directed medical therapy. Aspirin, beta blockers, inhibitors, statins. But if we look at it, the adherence rate for patients with cardiovascular disease, peripheral vascular disease, and coronary heart disease, the best reach 3/4 only. And agents that are proven to be work in survival benefits barely reach 50%. And it's not just they don't get prescription. A lot of the time is adherence for multiple reasons. So that's where cardiac rehab comes in. It's a multidisciplinary team that focus into the risk modification through counseling, education, behavioral intervention, and a prescriptive exercise program. And this is the goal, to empower patient to make it the leader of his own care. And to achieve that, it is extremely important to address the living partner and the family. So these are the patients that benefit the most. Right now, it's a class 1A indication by the clinical guidelines. Stable patients after acute coronary syndrome,